Welcome to our breakout session. Good to see you all. It's such a power trip to be on the mic. I never get mic'd. Thank you all for coming. I'll be introducing today's panel about public health emergencies. Thank you all so much for being here. So I'll introduce our panelists, whose names I did not ask you about, so I'm deeply sorry if I mispronounce them. Almost you could introduce yourself, but I think that's my job here, so I'll introduce you. So if we have Alistair Cook and Lisa Gong from the School of International Studies at Rajaratnam. Someone tell me what I should be saying.
Yeah, hi everyone. I'm Lina Gong, and here is with me is Dr. Al Cook. We are from the S. Rajaratnam School of International Studies and Nanyang Technological University in Singapore. It's a long name. Within that school, we have a humanitarian assistance and disaster relief program there.
Thank you so much. That was a million times better so thank you. Then we also have Samuel Boland from the Chatham House. And lastly, we have Adam Scott from Harvard.
Kamradt-Scott, yep. Hi.
So sorry. Yep, executive decision. I cut out half your name. I'm so sorry. Thank you guys so much for being here. Sorry about your names and your institutions. You are lovely people, and we're blessed to have you here. I think now I'm going to turn it over to you guys to start the conversation. Thank you again for being here.
Yeah, thank you everyone for being here. And first of all, we would like to thank Adam and as well as Alexandra, everyone here at Watson Institute for inviting us, having us. And before we start, we would like to give a brief introduction about our program. Our research is structured to three core pillars. The first one is about emerging humanitarian landscape within the Asia-Pacific or Indo-Pacific region, which we focus on mechanism, structure, etc. And the second pillar is about community protection and assistance. Within that pillar, we focus on five most vulnerable countries to natural hazards, two in South Asia, Bangladesh and Nepal, three in Southeast Asia, Myanmar, Indonesia, and the Philippines. In addition, we also look at two countries that are also affected or exposed to natural hazards, which are Papua New Guinea and Timor-Leste, which are having their systems developing at the moment. Recently, we also add to our picture the Pacific countries, two withstanding militaries, which are Fiji and Tonga. I believe some of you are aware that in that region, not all countries have standing militaries. So CMCOORD can be a bit different. So you need to add the police force to the picture. And then our third pillar is to look at the impact of emerging technologies on humanitarian work. For that part, we have developed a database that tracks the investments of military as well as civilian government agencies to do disaster work. And so today we are presenting our findings for our CMCOORD project. Oh, maybe it will be easier. It will be easier. I just talk from here. Our presentation will be consisting of three components. The first part will be trends, and the second will be scenarios, and the third part will be offering some pathways for future consideration and action. Al and I will take turns. I will be giving an overall picture of the operating environment in the region, and then Al will share more about the findings of our research about civil-military relations in the region and the dominant trends we observe, and then back to me, and then back to him to make some final observations. So the first few slides actually are just to give you a sense about how vulnerable the region is to natural hazards. The data are from different ways to show how vulnerable it is in terms of the number of hazards occur in the region compared to the rest of the world. As you can see here, earthquake, landslides over half, and then storms and floods, or the almost half of the world's total. And the second one is about the number of people affected and the fatality. And the third one is about how different hazards are impacting the region. In terms of the number of people affected, actually floods are affecting the largest number of people. Well, in terms of fatality, earthquake is the primary killer, I would say. And because of the threat posed by hazards to the region, it is seen as a security issue rather than a safety issue if you look at other parts of the world, such as South America. And in late 1990s and early 2000s, this region started to talk about non-military threats as a security concern, and natural hazards is one of them. And then so we are talking about this non-traditional security threat. This is a very popular term or common term used in policy discussions in the region nowadays or since late 1990s. Why is a security issue from the human security perspective? It threatens people's physical security. It threatens livelihoods. It causes displacement, which can be projected, which is opposite to our impression that maybe displacement caused by natural hazards can be a short term and people can return to their home in a relatively short time if you compare with armed conflicts, which turn out to be not the case in many countries or parts of the world. And then from the state perspective, it leads to question about the legitimacy of government. A classic example will be the Cyclone Nargis in 2008, when the military government initially refused to accept international assistance. And then that caused a big debate about whether military force should be used to open humanitarian access. So basically in that region, natural hazard is a security issue. And for security issues, you can be accepted or understood to take extraordinary measures. And within that region, there is also a history of deploying military as first responders. This is a bit different from the military as the last resort approach. And this set the background of our research of the operating environment for CMCOORD in the region. And another trend or feature of the region is that compared to maybe other vulnerable countries, regions such as Africa, it's relatively peaceful, which means CMCOORD largely takes place in natural hazard context, relatively peaceful context as well. So a bit background of our research. This is a continuation of our previous research. Currently, in our previous research, we categorize or group CIF-MIL coordination into four levels in terms of the depth of the coordination and cooperation. We call it 4 Cs. Later, Al will give you a more comprehensive introduction about the 4 Cs. And then within this research project, we try to answer 2 questions. The first one is, what are the current trends in CMCOORD in the region? And the second question is, how have the new or emerging risks have impacted CMCOORD? In terms of methodology, we have relied on semi-structured interviews with over a score of practitioners, scholars, and policymakers within Southeast Asia, the Asia-Pacific, and beyond. And we also draw observations from our participation in regional and international CMCOORD events. Now I'd like to pass the floor to Al to continue our presentation. Thanks.
Thanks, Lina. So just to briefly outline some of those experiences that we've been documenting, we wanted to really see within the civil military coordination space, and we look beyond sort of the UN CMCOORD functional definition of it to being more civil military relations, or how civilian agencies interact with militaries in the region. There are different ways that we're hearing now that agencies and operational practitioners are using it to different ways of framing it. But essentially we looked at who was involved in some of these responses. Did they have pre-existing relationships? What were they based on? Were they formal, informal? Were they based on SOPs and so on? And how do we best understand these? So as Lina mentioned, we look at the 4 Cs. Now, there are a lot of different policy documents in the Asia-Pacific that document these in different ways. But the best way, I think, to understand it is on a spectrum from sort of the least interaction to the most interaction. So coexistence and communication is essentially what we would think of as deconfliction, so making sure you know who else is in the field and you don't get in each other's way, up to collaboration. There are varying degrees here of understanding that. So in terms of cooperation, this might mean you've got some piecemeal ways of engaging and establishing patterns of, well, they call it cooperation, but of engagement, let's say that, but it's not predictable, that it's more reactive. Then it goes through to coordination, which is where we see some of those SOPs. And Lina alluded to earlier MADRO, so that is the regional version of Oslo guidelines. So this offers a bit more of a context and a reference document. And then we go through to the higher end or higher order of partnership or engagement, which we call collaboration. And that is looking at some of the legally binding mechanisms that we have, like in the region, ASEAN Agreement on Disaster Management and Emergency Response, which documents different roles for the actors within emergency response. So how does this get shoehorned into this panel? We've also been looking at the pandemic. So during COVID-19, there have been a series of different humanitarian situations which have been ongoing, and particularly when we're looking at the role of the militaries within the region. So what we're presenting here is part of that story, focusing on what we've seen during natural hazards within COVID-19. So the first thing is that even though we have a policy framework for military engagement in the region, in particular areas, whether it's natural hazards or within perhaps even pandemics, often what we see is it's largely informal, but even if it is, it's logistics focused. But in reality, what we saw was that it went far beyond this in terms of their engagement during the pandemic. So what were some of those areas that we saw? And then this will feed into what they ended up doing also during the natural hazards that we experienced in the region. So a couple of them which we've perhaps are not always thought about, and maybe Adam will talk more about this in his presentation later, but we saw them engaged in vaccine rollout. We saw them engaged in implementing lockdown, and we also saw them engaged in more camp management in the natural hazard response, so that they were using their facilities for evacuations when the social distancing when social distancing was being restricted during the pandemic period. Now, broadly, what have we seen? The engagement both during the pandemic, but also in natural hazard response. There are a few areas that we focus on in the Asia-Pacific, which I think that there are some current trends here that are quite interesting, and I think we should perhaps spend some time talking about it. Some of the ones you would expect to see are in quick onset, so some of those typhoons, cyclones, and so on. Less expected in slow onset, so droughts, and perhaps you do see it in floods, but often these are left to civilian defence forces or the emergency services. And what we also have noticed is that there's a tendency to rely on the disaster management function as a default in the region. Now, whether or not this is appropriate, and I think we'll hear more about it when we look at regional frameworks, but they tend, because they have been quite successful so far to date in responding to natural hazards, they tend to be used as the lead agency in areas that perhaps are outside of their areas of expertise. And for now, I think the only other trend here that might be worthy of further discussion later is on this localization issue that we see in the region, and that is where we've noticed within the region that localization has often meant that we're seeing a default click back to nationalization. So it's being used as a way for national governments to become a gatekeeper to particular humanitarian emergencies, and we saw this during 2018 during Sulawesi in Indonesia, and it was being framed as a localization effort, whereas in fact it was one way that the government was using this global trend to increase the barriers for entry into some of those situations. So during the last couple of years, what have we seen in COVID? And just I want to briefly highlight these ones, is that we've seen super typhoon in the Philippines and then tropical cyclone Harold in the Pacific. And what we have essentially witnessed was the impacts of that on disaster response, being evacuation efforts were cut down to 50%. We saw that quarantine measures were affecting relief supply, and that the ability for them to prepare for the next disasters was severely limited in terms of preparedness, and this caused a real challenge. Now I'm just going to quickly go to this one here. So broadly, I think what we've been seeing, and I will hand back over to Lina here in terms of talking about the regional mechanisms, is that we're starting to see a greater focus within the Asia-Pacific on some of the regional mechanisms within ASEAN, that there has been an effort to promote some of that early structured engagement, but that's been severely hampered during the pandemic. But also one of the other issues that's been continually a problem that we're noticing has been over the ability to capture some of the what we call knowledge management and transfer, which is that we're repeating the same mistakes from one disaster to the next, whether it be in a natural hazard environment or in pandemics. But I'm just going to hand over to Lina for a brief overview of the regional structure.
Yeah. Within the region, actually there are a variety of regional mechanisms for disaster response, within which CMCOORD coordination happen in different forms and to different extents. We are just giving two, we think, representative cases. One is ASEAN, and the other is a friends mechanism. For those who are not familiar with this is loosely this is a mechanism involving France, Australia, and New Zealand to respond to disasters in the South Pacific. With regard to ASEAN, we find it that it's highly institutionalized. It's a regional agreement, as Al just mentioned, that at ADMER, ASEAN Agreement on Disaster Management and Emergency Response. Within that, it gives different roles definition for different actors, and so these framework governed disaster response by the military and civilian agencies as well as international cooperation within the region. And it also has its operational entity, which has been evolving from just a coordination actor to be able to a provider of disaster response itself. And within ASEAN, it also has the vision document that sets forward the kind of disaster response or disaster management they hope to achieve within within 10 years' time. So back to this mechanism. So on the civilian part, our observation that ASEAN has been achieved a high institutionalization. It has all these elements to be able to operator or actor as a disaster responder. And in 2018, when Indonesia was hit by a triple disaster, which was earthquake, tsunami, and liquidated and basically, and then AHA Center was tasked by the Indonesian government to coordinate international response or response from the humanitarian sector and private sector. And the OCHA was embedded in the AHA Center, which suggests a trend of the rising importance of regional actor. Well, on the military side, it's a bit different. The coordination, military to military coordination still occur at bilateral level. It has yet to be achieved the multilateral coordination level. So, and then with regard to France, it doesn't have these kind of established institutions as what we have in ASEAN. However, because of the close relations between the three countries involved, they are all major providers of HADR in the region, and then they have achieved a quite effective, good level of effectiveness in terms of operation. And then ASEAN has an evolving policy agenda. Within, I think 2 years ago, in 2021, we are tasked to conduct a midterm review to look at the progress and weaknesses in ASEAN's disaster management system. So these are the four issues we identify. For the sake of time, I will keep it brief, but we can provide more information and details if there's interest from the audience later. And then here are three risks that we think that will impact CMCOORD coordination now and in the future. One is climate change. All these are reasons why we need to relook at CMCOORD in these contexts, particularly whether we are going to see beyond CMCOORD beyond response only to extend to maybe DRR and other phase of disaster management. And then with regard to public health emergency, one issue or point that I observe is that the leading agency may be different. In natural hazard, it can be the National Disaster Management Authority, and in this case, it may be the Ministry of Health. So whether that difference will have an impact on CMCOORD. And then the third one is the political dynamic, whether it's at national level, such as Myanmar, or regional and international level, is another factor that need to be considered in CMCOORD coordination. Now I'll give the floor back to Al.
Okay, so just to wrap up, this has been sort of a very fast run through of what is going on in the Indo-Pacific. But in conclusion, before I hand over to the next speaker, I think what I would just finish in saying, without going through the remainder of the slides, is that what we have seen within the region is that there has been, as Lina mentioned, significant institutionalization in terms of the natural hazard response, so the NDMOs, the National Disaster Management Offices, and this is being seen as a main example of how governments want to be cooperating in the region, whether it is within natural hazards or whether it is within pandemics. They're trying to take lessons from that sector in how to do it. But we're also seeing that at the regional leadership level, that a lot of the focus has been on disaster management sector to be operating in areas outside of what we would normally consider its primary focus. So we've seen them being engaged in terms of deployments in political contexts where the local dynamics are a lot different to natural hazard environments. So overall, I think that there has been a lot within Southeast Asia, particularly in terms of institutionalization, but it doesn't necessarily translate into these other issue areas like pandemics or political risks like conflict. And with that, I think I'll stop here and happy to continue the conversation later and hand over to the next speaker. Thanks.
Thank you very much. Does anyone know how to swap this to the next PowerPoint? Is this your laptop? Okay. I've got it on a key if that's better.
So this is what I have for presentations for May 2022, and it's not the same, right?
Is it all of them together? No, this is just that.
Do you want me
The
to just-
second one I have email is.
That's me.
That's just you?
Yep, that's me.
Awesome. Download. And while we're here, I might download this one too. No, I won't. Yeah, this is you.
Sweet. Thank you very much. Thank you. Hi everyone. Afternoon. Hope you're doing well. Apologies in advance to those that have been at this conference the past couple of years, because you've probably heard me talk about this project more than once. It's been going on for some time, but is now, as of about a year ago, concluded. This was the topic of my PhD, which, while I'm now at Chatham House, was with the London School of Hygiene and Tropical Medicine, and it was looking at civil military response to the Sierra Leone Ebola outbreak back in between 2014 and 2016. There's a lot of overlap thematically with the presentation that we just had, and I'm getting ahead of myself, but just to kind of frame up a bit where this is going, I think that a lot of the chat about local NGOs and civil society organizations and the extent to which they're often underrepresented in these kinds of crisis response as related to the question of localization and nationalization, and ultimately reflected in the theme of, to what extent do you do a top-down response to these kinds of urgent global crises versus have a grassroots one, and trying to figure out how to square that circle and maybe try to draw lessons from both and find solutions that allow you to engage the strengths of both of those different kinds of approaches is ultimately really what this research is about. Like I said, I'm getting ahead of myself, so I will jump in and over the next 20-odd, 25 minutes, quickly just go over what the aim of this big research project was, go into the absolute top level of the background, talk a little bit about methods, and then get on to some of the findings, and then we can swing to sort of recommendations and stuff like that in Q&A. So, really straightforwardly, in relation to the militarized support to the Ebola response in Sierra Leone, the overall aim of this research project was to examine the origin. So essentially, how did it come about? Both the British and Sierra Leonean militaries were very, very present in responding to that epidemic in Sierra Leone. What was its nature? What did it look like? And essentially, how did it work on a day-to-day basis? And then also, what effect did that have, both in terms of the effect within the response itself, but also perhaps some of the sort of political consequences for what that means in how we respond to public health emergencies. Background, you all know this. This is all that I'm going to give at the moment, which is that 2013, really, because it kicked off in December in Guinea, West Africa Ebola Epidemic was the largest recorded outbreak of Ebola to date. By the middle of 2014, things were escalating very, very quickly. Response actors in Sierra Leone, as in the other two main affected countries of Guinea and Liberia, were becoming fairly quickly overwhelmed. And in Sierra Leone, the British government, towards sort of the end of the summer, announced Operation Gritrock, which was a military mission to support the response to Ebola in that country, alongside the National Army, I should say, which is key, and we'll see where that's going in just a moment. Really, really high-level, brief sort of timeline here, just in terms of how that was activated, at least in terms of how it was activated, like in the public domain. Sort of early-ish September, you had the new architecture that was a civil military architecture proposed by President Koroma, the president of Sierra Leone, and also the British government notifies the British military to be prepared to deploy. By mid-September, you have the government announcing JASIF, the Joint Interagency Task Force, and also Operation Gritrock, formally, publicly. By the end of that month, so we're talking about a very short period of time, you have the main contingent of the British Armed Forces arriving into Freetown. By the middle of October, you have a new Civil Military National Ebola Response Center, the NERC, that supersedes the Ministry of Health and WHO Ebola Response Center called the EOC. And by November, December, you have a constituent network of district Ebola response centers, which are inherently civil military coordination centers being sprung up around the country. So basically, how did that happen? What did it look like, and what does it mean? In terms of methods, this was a PhD research project, so it got relatively theoretical and took a number of years. Conducted far too many interviews, did 110. I actually did 200, but that's beside the point, because there was a stakeholder group I didn't end up including. 110 in-depth interviews between 2017 and 2018. I should also add I myself was an Ebola responder. I was there from the middle of 2014 to the relatively late in 2015. So site selection is quite biased because I chose the places that I had worked, and I spoke to a lot of the people that I had worked with. Range of civilian and military Ebola response workers, ERWs, and I did that at as many levels as I could. So I went sub-district to the chiefdom level, district level, which is where most of the daily operations were coordinated, national level for national coordination, and then also international level. So Geneva for WHO, London for British government, Atlanta for CDC, etc. Alongside that, filed a couple of Freedom of Information requests to get some background knowledge as well, and was able to sort of compare and contrast those interviews alongside some otherwise undisclosed government documentation. This is the kind of broad overview of who was spoken to. As you can see, it's across the board. There's reason that there's a bias towards the British government rather than the American is because America was mostly responding in Liberia. So it was mostly the UK government, Sierra Leonean government, and then UN, INGO, paramount chiefs, which are local traditional authorities. And most of the US government officials there are actually US CDC. They were grouped into whether they were military or civilian, and then also what level they were, as I described. The theory of the thesis, because it's essentially a social science degree, and so this is where it's a bit left field to some of the other discussions, not all of the discussions, but some of the discussions at this workshop, is that it's really an anthropology degree. My degree is public health and policy, but this is really about trying to actually figure out how different groups of people with different backgrounds were working together on a day-to-day basis. This is a really top-level description of what that methodological framework was, but essentially what that can be understood as in terms of how to interpret the actual data was the theories of a woman called Mary Douglas. She was a neo-Durkheimian theorist, and she has this theoretical framework that suggests that the ways in which an organization exists, social organization, you have a sort of mix of different forms of ways of working. You have a mechanism through which that's enacted. That's your daily, quotidian interaction, which really just means your day-to-day routine. And then that cultivates a way of thinking. And the way of thinking itself goes back and reinforces the organization at hand. So as applied, for example, to military, the general idea would be the hierarchy of a military organization means that you're going to act on a day-to-day basis like a soldier, which means that you're going to think like a soldier. And if everyone around you is thinking like a soldier, then that means that you're going to reinforce a military hierarchy. That's the idea. So, again, very high level. In terms of origin, each one of these slides is like a whole paper, so I apologize for really glossing over them. Basically, the origin to a large extent in Sierra Leone, was that there was a very small number of people, both in Freetown and then alongside some conversations in Geneva and London, but a really small number of people in Freetown that had been advocating for this before it came to the attention of Whitehall, before it necessarily came to the attention and the decision-making nexus in Washington, D.C. And that has some fairly important implications. And for each of these slides, I've kind of just got a quote to give you a sense of what we're talking about. And on origin, unfortunately, we can talk more about it in a bit. This is one of the sort of key quotes of one of those key people. We're talking about a group of about 8 people. But we'd been planning it, as in to bring the Sierra Leonean and then the British military in, and plotting and scheming for 2 weeks, mapping and planning, getting all the resources in place, working it out with RSLAF, which is the Sierra Leonean Armed Forces, looking for somewhere where we could base the command center. And what no one knew is that our coup was not just going to be about burials. In short, that initially getting military support was to support the collection of corpses in Freetown. It was about proving the command and control concept and then taking it all over. Nobody knew that, and we were essentially trying to launch a coup against the Ministry of Health and Sanitation in Freetown. That snowballed from there, and eventually, and again I can talk about this in detail in Q&A if people are interested, to a large extent, into what came thereafter, which was Operation Gritrock, Operation Octopus, which was the Sierra Leonean contingent. In terms of nature, basically there is a fair bit of dissent, but across all respondent groups, military's intervention was perceived to be valuable, perceived to be life-saving, including for the establishment of the command centers. And a lot of times when people talk about this and think about this, this is the kind of stuff that we're talking about. And this is very relevant in Sierra Leone, but it's actually not where I'm going. So a lot of people talked about things like sciences, services, logistics, security, engineering, personnel, and so forth. That is all really key and really central to the contributions that were made. It's not specifically the focus of what I looked at, which was much closer to the feeling as an Ebola response worker of how did the presence of the military and how did the organization of those command centers change the way of working? How did it change the culture of working? And so that is sort of brought out by these couple of quotes. So to inject that military officer into the discussion, that had an effect, these are quotes again, that had an effect on how the chiefs organized themselves and how the villages organized themselves, because you just need that one planner, that one logistician, and then pretty much people can help themselves. Alongside, just to reinforce the same point, if you're working with someone who's disciplined and looks focused, you're also going to dance to that tune. Is that not so? So we copied from them, as in the military, what we thought was very good in terms of discipline so that we can save the lives of people. So how did that happen? How did having the military present mean that civilians who were working the response were perhaps working more quickly, working with more discipline, and so on and so forth? So this is really the heart and soul of a lot of what the research was about. At the same time, though, and this is where, again, it's a big can of worms, there were some harms that the deployment of military had, and predominantly, getting back to that question of localization and national responsibility, it was to do with the fact that some public institutions and local groups were perhaps to some extent not sufficiently included in the formal response, which meant that capacity wasn't necessarily built as much as it could have been, which meant that Sierra Leone remains a bit vulnerable to future crises. A Ministry of Health official put it like this: it was like you found yourself in an ocean in a little canoe, the Ebola response, that is. And there are waves and a hurricane, and you're lucky to escape. Now that I know, as in someone in the Ministry of Health, that it's a hurricane, now that I know it's a hurricane, I would use a bigger boat. I would then know everything that's involved in surviving, and I would go against the hurricane, and I would be self-reliant. And we would have a system that you can be proud of, and that the health system in this country can handle the situation on their own. We don't need the military any longer. I should have confidence, and I should be restoring confidence in my military teams. Essentially, that didn't happen because the Ministry of Health was to a large extent pushed aside by the choice of the president. So it was a civilian decision, but the Ministry of Health became sidelined in the operation of their core mandate. So a lot of people were very upset about that and felt like it didn't allow them to build up the institutional strengths that they needed to do well. Again, glossing over way more detail than I can go into at the moment, this kind of cycle, or can be conceptualized as a kind of cycle, which becomes to some extent reinforcing. So this is something in the research that I went ahead and called the political economy of expedience. It was very convenient and necessary to some extent to bring the military in when they did, but at the same time it leaves the institutions weak and vulnerable, which was the reason that they had to come in the first place. So you get this kind of loop, which means that you're not necessarily actually working to intervene and interrupt, and to perhaps prevent the need to bring the military in the next time. So this is where we get onto the localization thing and trying to square that circle that I started with. I think, and I argue, and I think the research shows that actually a militarized response gives some lessons on how a hierarchical space or a hierarchical kind of response, a top-down response, doesn't actually need to be an exclusionary one. And I know that there's a lot of sort of big academic-y loaded terms in here, but essentially, when organized in the right way, a type of hierarchy can perhaps actually really help facilitate localization and the ability to have a grassroots response. And I'm going to talk a little bit about why and how I think that that's possible and how I think that the Sierra Leone Ebola response and the military's involvement in it allows that to be the case. Starting with this general idea, just as again very high level, kind of glossing over some things. In Sierra Leone, you had the traditional epidemic response mechanisms become really quickly overwhelmed. The civilian agencies, institutions, public institutions, MSFs, the INGOs, the World Health Organization, they were like out of their depths in terms of trying to figure out how to contain this without exogenous support. So you have the military intervention, which puts these command centers in place. A group that are in this research are termed classical response actors. That just means sort of normative actors. Again, the INGOs, the MSFs, the government public health actors, and so on and so forth, are asked to participate in and are folded into those structures, which means that more actors become involved. And as more actors become involved, you have a greater need for coordination and oversight and accountability. And once that's in place, you actually have the bandwidth to have more people and a bigger diversity of people engaged in operating in response to the same overall shared mission. Once those people become involved, you have a greater need for accountability and coordination and oversight, and you can start to develop a kind of virtuous cycle that allows more and more people to become involved, in theory and ideally. So the point is, though, that it's not just in theory. So these are some of the most local actors that were involved, and these are the perspectives of some paramount chiefs. They're not the most kind of quote-unquote ground level, but they're very, very close to the communities that they serve and well below the hierarchy that the civil military coordination centers were designed to exist at. The idea before the Ebola outbreak was that military personnel are somebody that cannot laugh and cannot talk to anyone. But the first time I met these military personnel in the DIRC, in the district response centers, you could not know that these people are military personnel because the way they talked to people and the way that they responded to issues, they did not even behave like the military. They were so soft. They made us understand, as paramount chiefs, that the military personnel were just normal human beings, and the only difference we civilians have compared with them is discipline. This is a different individual making a related and similar point. You see them always active, them being the military, and want to do things on time. To see that things happened when the problems, and that the problems were solved, even if you had any concern and you went to the DIRC, you would be perfectly received by them with a smiling face, ready to listen to you, and ready to solve your problem. Immediately you would see their commitment, and they would communicate to the responsible person and say, this is what the paramount chief wants. So essentially, their military personnel were advocating on behalf of greater inclusion of local authority and local people, and trying to help make sure that they had the resources and the support that they needed. To continue the quote, that's how I believe they helped the people to come out of the Ebola outbreak. So if one is to rate the participation of any participants in the Ebola response, the military will be the first of the people or groups that helped to eradicate Ebola in Sierra Leone. And again, this is a very, very local perspective on the militarization, which is often characterized as top-down and exclusionary. The kind of theoretical summation, ultimately, of all of this is this graphic here, which is again, swinging back to how I started, trying to square a circle about how can you have top-down, efficient, expert-driven response in a way that actually permits and builds up a grassroots level. And essentially, the argument is, in Sierra Leone, it didn't work perfectly. There were occasions when people were pushed out of decision-making capacities by the top-down response. But by having the hierarchy in place, by having the militarized coordination in place, it meant there was accountability, it meant there was oversight, it meant that there were systems in place, essentially to use the military hierarchy almost like a mission command structure and model, where instead of it being about top-down direction, it's about giving people the resources they need, giving people the information they need, and using that hierarchy as a mechanism of supporting people lower in the chain. That meant that more people could be involved than might have otherwise been. And if you extend that principle, you could, in theory, get to a kind of inclusive hierarchy, where you have people, as many people as care to be involved, capable of being involved, using the kinds of tools that the military uses to make decisions really fast in the field in response to crisis. That's what those tools and those systems and those architectures are there for. Ultimately, I'll just leave one final quote before handing it over to Adam, which is just always to reflect and remember on this. So in my field as a humanitarian aid worker historically, and also doing a PhD in anthropology, you get a lot of biases about the role of the military. This is a Sierra Leonean perspective rather than one of a sort of UK London-based colleague who said, when you're in a crisis and people are dying, what are you going to say to a mother who lost her child? I'd like some of this person characterizes as arrogant and ignorant commentators, essentially those who, in this person's thoughts, advocate against the use of military in these spaces, to put themselves in the shoes of a mother whose child is dying and 4 of her other children are already dead. Her husband is dead, 6 of her extended family are dead. I would like these people who talked about the militarization of the Ebola response to go and tell that woman, your child is going to die because the only person who can help is a soldier, but we don't want to send a soldier. So, I'll leave the Q&A for later after Adam's presentation. I'll stop there. Thank you very much. I'm not sure how to pan away from this, so I'll just leave it.
Okay.
I realized I almost seen my email earlier, which I don't have anything to hide, but get out of this. Is this is you?
That's me.
Oh, this is great. Okay, but now I
See,
need to
I've already got it. You
Oh,
sorted.
don't
You're
don't
all
jinx
good.
it yet. I don't know. Well, this looks good actually. Okay, and they've been doing this because I've actually never used it. How do I find
That's
the
right.
present?
You can just do down here to set it going.
There.
Yep.
Well, this is so good. I'm learning a lot today. All right. Where hopefully I need to go.
Yep, there we go. Awesome. All right, good afternoon. Last presentation of the day, I think. Just to introduce myself, my name's Adam Kamradt-Scott. I've recently joined the Harvard T.H. Chan School of Public Health as a visiting professor. Prior to that, I was in London at the London School of Hygiene and Tropical Medicine, then at the University of Sydney, where this research actually started, and then I spent a brief period in Italy during the pandemic. So there is a little bit of background and context to this research. So it started out actually as a result of my time in West Africa during the Ebola outbreak. Went and led a small research team to look at the civil-military response. We produced a report at the conclusion of that research called Saving Lives. The copy of the cover is there. And from the basis of that initial report, I then was able to obtain some funding from the Australian Research Council to investigate civil-military cooperation in health a little bit more deeply. And so the project started initially sort of focusing on the West African Ebola experience, but then I expanded it out to include polio eradication in Pakistan and Zika containment in Brazil, where we also saw militaries involved with sort of health-related programs. Part of that research involved a survey which was completed by 594 individuals across 3 different cohorts, which was looking at military personnel who had been involved in health emergency crises, humanitarian responders, and then government officials and representatives from international organisations. The survey was available in 9 languages and distributed through a variety of different networks. I managed to undertake fieldwork and go back to Liberia in 2019. I was actually then due to travel to Sierra Leone in February of 2020. The Sierra Leoneans actually said to me at that time, it's okay that you're not coming because we've heard that this new disease called COVID has hit Australia and we were worried about you coming to our country. So the fieldwork that was due to happen in Sierra Leone and Brazil had to get cancelled. But as a result of that, it created an opportunity to pivot the research project to then survey what was happening in response to the COVID pandemic. And so as a result of that, the research then really focused on the role that militaries were being asked to play with regards to COVID-19. The process then was largely, obviously, because travel was very much restricted, especially from my home country of Australia, to focus on open source data collection. And from that data, we were able to identify 64 discrete functions that military personnel were being asked to perform around the world in various different countries within 14 sort of broad categories. And that's the research that I'm just going to show you a glimpse of today. I'm just going to narrow down on 2 of the areas and then sort of break them down further into different sort of functions and then talk about some of the key findings from the research so far. With the research, we decided there's obviously, because it's covering multiple countries, there's multiple different ways you can break down the data. For the purposes of this presentation, I broke it into WHO regions. So when I'm talking about the European region, it's actually referring to the European Union as not the European Union, but the European Office of WHO and the member states in that cohort. And the search terms were, I engaged a research assistant to help with this in conducting the searches and just double checking all of the data, working across 4 different languages. So it's not all 6 UN languages, I will acknowledge, and it wasn't as extensive as the survey, but nonetheless it gave a sense of different sort of roles and functions. So from this, you can see that the primary role that militaries actually ended up performing during the first 12 months of the COVID response was primarily really helping with increasing healthcare facilities and supporting civilian authorities in providing healthcare. And we saw this manifest in a number of different ways. In a number of countries, we saw that military hospitals, which were otherwise designated for military personnel and their families, were repurposed to provide care for COVID-19. And I'll use the example of Liberia because I was there just as their latest and newest military hospital was being opened on the outskirts and across the way from the military barracks. And they were very proud in November 2019. It was about to be formally announced by the Defence Minister that this new hospital facility had been created, and then they very quickly, their first patients that they received really were COVID-19. They became the national designated hospital for COVID. We also saw a lot of military medical professionals being deployed into civilian healthcare facilities as well to supplement services. And then we saw sort of the militaries being called upon to perform, I guess, a more standard sort of function that you usually expect militaries to sort of play, which is more sort of around enforcement and protection type arrangements. So I'm just going to go down into a couple of different categories, but as I mentioned, I broke the data into WHO regional offices. So the yellow is the European regional office, the green is the African, there's a red which is Mediterranean, and so on. So you can sort of get a sense immediately from there, like which countries actually ended up or which regions actually have much stronger role with military participation. Now again, I need to stress this is just the first 12 months of the COVID response, so from the data that you will see, you may sort of go, oh, but in my country they did X, Y, Z. Well, that may very well be the case, but it may not have been necessarily in the first 12 months. So when we look around the world, what we find overall is that from the data, there were 103 countries around the world that utilised or called upon their military forces within the first 12 months to provide some form of assistance. That represents 53% of WHO member states, or if you take out those countries that don't have a standing army or a military, then the increase is up to 61%. We also did a bit of a heat map to sort of show which countries were more inclined to use their militaries across a variety of different functions. My own home country there, Australia, is in amongst the highest percentage of countries calling on militaries to do a variety of different functions. And when we break it down through regions, again, a slightly different version of the heat map, but also showing percentages with regards to the number of countries that were being asked to actually play a particular type of role or function. So you'll see there, for instance, European countries, increasing health care facility capacity was a pretty common request across the board. So this was just focusing on a healthcare facility, again, sort of represented in a different variety. But the second function that I'm going to provide a sort of closer breakdown into and go into different areas was the sort of role in helping or augmenting the civilian health workforce capacity response. And when we look at, and so we broke this down into a series of different categories and sub-functions. So one of the first ones was actually having military personnel being engaged and utilised to assist with contact tracing and epidemiological support. And so you can sort of see here that there are a number of countries around the world that were utilised their militaries to call upon to play this function. Let me delve into a little bit with the context of Australia. So this was an unexpected development for the Australian Defence Force. They were not anticipating that they would be called upon to assist in this way, but it became particularly prominent with the Victorian state of Victoria, which went into a protracted lockdown. It ended up being one of the jurisdictions that had the longest continual lockdown in the world. And as a result of that, the Victorian government asked for assistance from the Australian Defence Force, from the federal government, to help with contact tracing to make sure that people were actually staying in their homes. That became actually a little bit of an issue in some of the areas where we had refugee communities, or a large percentage of refugee communities, because understandably many of them had fled war or some form of violence, and so we were even concerned that using people in uniform to turn up and knock on people's doors in the middle of a COVID response, and they were not getting a response. The doors were not being answered, and so then they were being marked down as being non-compliant with the stay-at-home orders. That this was actually potentially problematic because of the nature of the people that were being asked to conduct the contact tracing. But nonetheless, those are just sort of some of the issues that even arose within our own country with this sort of type of role. We saw a number of countries utilising their personnel to conduct testing and screening, and particularly with sample collection. I won't delve into that one too much, but one of the instances there, we did see a number of countries also utilise military aircraft and personnel to help repatriate citizens that had been either put into lockdown or one other, like being prevented from returning home to their country. Japan is actually not highlighted in this slide, but they were a good example where the SDF were called upon to assist repatriation of Japanese citizens that had been locked down in Wuhan, and so they were called upon to go over to Wuhan and coordinated with the Chinese authorities to get their citizens out and to get them back to Japan. Many of you may know about the role that Australia played with our quarantining facilities. What we did see was that a number of Pacific islands utilised their militaries in this way to assist with quarantining of incoming arrivals. So Australia, New Zealand and Fiji, as three examples, ended up utilising their militaries, again aided by the fact, I guess, that they were an island, so it was a lot more easier for being able to identify people coming in. Whereas across many other countries that had shared land borders, it was a little bit more difficult and problematic. We actually saw militaries even being called upon to take over running civilian hospitals in a number of instances. So in, there was one of the countries here, was Spain, I think it is, that was actually called upon to manage 80 the Army and Navy were called upon to manage 80 civilian hospitals. In decontamination roles, so we actually saw, for instance, the South Korean chemical, biological, radiological, nuclear team were called upon to help decontaminate facilities after caring for COVID patients and to prepare them for potential COVID arrivals. So again, a lot of different sort of roles and responsibilities being called upon, and various different sort of administrative assistance roles. One of the more interesting or controversial topics has been around the role of militaries in vaccination. Now, I need to stress again that because this study completed at the end of 2020, many countries were still in the process of actually ramping up their vaccination drives, and so vaccines weren't widely available. What we did see, and what you can see reflected in a lot of the reports, is that militaries were being called on quite extensively to do the planning and preparation for it. But we focused then in this data in terms of a couple of different functions. And I think probably one of the more interesting ones, which often gets overlooked, and I empathise here for military personnel, is that they were used to test the vaccines upon. And so we saw that both across Russia as well as the People's Republic of China, and there were some volunteers included in the US military as well, where they were actually testing the vaccine and to ensure its efficacy and safety. In some of these countries, obviously, it wasn't necessarily so much of a option. There was not even necessarily that they were voluntold. They were just utilised in that way. And I think it's important to recognise and appreciate that that sometimes is overlooked when we think about public health safety and the people that get called upon to contribute to said safety. We saw as well, obviously in the United Kingdom, the UK Defence Force was called upon to help with the construction of vaccination centres, so actually building areas ahead of the mass vaccination rollout. And then we're also involved in the logistics and distribution. Now, if we were to look at this even 6 months later, you would see obviously the map would be very different. Because the militaries were called upon quite extensively throughout 2021 to assist with both the distribution as well as the administration of vaccines. And so that's probably the second phase of this project, which I'll come to in a little bit. So let's just sort of take a step back and look at some of the major sort of implications from the findings so far from the data. And the first one is that really there was quite an extensive and diverse range of roles that militaries were called upon to assist. 64 different discrete types of functions, some of which could be broken down fairly extensively even further into different sort of roles and responsibilities. And what that highlights really was the fact that we don't really, or we did not, at least at the beginning of COVID, have a very clear sense as to where the red lines are, as to what militaries should be asked to do versus what they should sort of stay away from. And we saw that governments were very willing to utilise their militaries when the chips were down. The other interesting element really was, in comparison to other events like the Ebola outbreak, there was actually very little foreign military assistance. It was predominantly focused on domestic context, which was understandable given the circumstances. There were, however, a number of instances where militaries were called on, even in the first 12 months, to assist either with providing military personnel, military medical personnel to another country, but oftentimes we saw militaries being called upon to help with logistics and transport, so utilising their military capabilities. As I mentioned, 103 countries, which was 53% of WHO member states. If you then take out those countries that don't have standing armies, it actually increases to 61%. The most common function, as I mentioned, was supporting civilians, healthcare delivery, and that was both with regards to provision of facilities as well as personnel. But then it was very much after that followed by sort of more conventional security functions such as protection, enforcement of quarantine facilities and so on. When we look at the findings as well, it is interesting to note that actually it was, I found it interesting at least anyway, that European countries were overwhelmingly more inclined to utilise their militaries, to call upon them, than many other parts of the world. And then if you look at some of the different ways in which the militaries were utilised, the Southeast Asian regional countries were more likely to use their militaries to supplement healthcare facilities, assist with logistics, and assume national leadership roles, which kind of very much aligns with the data that was presented earlier, that there is a tendency or a trend there, and a willingness to more readily utilise militaries in these types of functions. If you contrast that though with the Eastern Mediterranean countries, the militaries there were used much more in sort of conventional security functions. So that was what we sort of saw them being called upon most frequently to perform. And these sort of other roles around military medical professionals helping was less common. And the other aspect, I think, which was also quite interesting, was that when we look at the sorts of a lot of anxiety, obviously, around the role that militaries could be asked to play with regards to a health crisis, but in actual fact, we sort of saw fairly consistent roles and responsibilities across the board. There are, I think, some limitations to the study, which I do need to flag and acknowledge, and that is fundamentally this was utilised through a series of Google searches, ultimately, using open source data, and there are problems with doing so. We tried to be as comprehensive and expansive as possible, but nonetheless, there are no doubt countries that have slipped through the net. It is limited as well to the first 9 months of the pandemic, so we commenced it from the 1st of March through to the end of 2020, so it's 9.5 months, but, you know. And in that respect, I think if we look at what came after in the following 12 months, again, you would see a change in the role and functions that militaries were being asked to perform from the first 12 months to the second 12 months. The search was limited to 4 discrete languages, but it was also primarily English source languages that were utilised. And what we sort of saw was that media reports would often, there was less coverage of reported human rights violations and violence than what we were anticipating. There are a number of countries that were identified in media reports whereby militaries were involved in human rights and or violence in enforcing their orders. Now this aligns with the research that we did with the West African Ebola outbreak as well, that there are instances where violence does occur, which is obviously antithetical to public health endeavours and not something that we would want to see repeated. But this is one of the sort of limitations, I guess, with this sort of language, and there's a variety of reasons as to why that limitation may exist. It may be, for instance, that reporters that are actually based in the countries are unwilling to report on that because they have concerns over their own personal safety or issues to that effect. I had been hoping that this would be the first study that would actually be published, but another team actually beat me to that to claim the credit for the first global study, which is Erickson and colleagues. And I've had a look at their paper, which was only recently published, so it's just come out this year. Their data, they've stated that they found that 95% of countries actually utilise their militaries in some way. I've tried to go back and look through, we actually basically copied and pasted every media report that we utilised for this study, so I have a very large Word document which is very unwieldy to work with, where with all the links and so forth that was utilised. And I've tried to sort of go back and go through that as well as doing additional Google searches to try and identify some of the countries that they say that they've found data on. And I haven't been able to do that. So I will acknowledge that there is a difference between the two studies. They also did, though, include police and paramilitary groups in their study, which we have tried very much to exclude. We were particularly focused on more traditional military, so Army, Navy, Air Force, without focusing on sort of paramilitary or affiliated groups. And so these may explain some of the reasons why we see differences in the studies, but nonetheless, there's some different elements there. One of the joys that I'm going to have while I'm at Harvard over the next year or so at least is to actually get into Google Alerts. So we set up, as the study was coming to an end for the first 12-month period, I set up a Google Alert using all the same search terms. And I just looked at that again the other day in terms of the number of emails that we've got. I've got now 4,600 different Google Alerts to go through and scrape through media reports and the data to sort of see from the 20th of December onwards as to what that data would show and the different changes. So hopefully, in the event that I'm able to get some research assistance and some funding to help me trawl through that data and start doing some mapping, then that will reveal some other interesting results. I will just make mention, obviously, I'm sure all of you have seen the guidance document that WHO released in late 2021. I was involved in helping the team in WHO develop these guidelines. It did come a little bit too late, which was regrettable to help countries in any sort of meaningful way. What it really sort of points to, though, is the need for focusing on building multi-sectoral collaboration. And that includes looking at things like the legislative framework that countries operate and militaries operate, and civil-military cooperation occurs, capability mapping, and then really sort of joint civ-mil training. And I can't stress that enough. I mean, so from some of the findings that we heard being presented by Jonathan, for instance, this morning, many of those were replicated in the studies and the survey data and the study that we did in West Africa during Ebola as well. And what his presentation was really saying to me was that there's still so much more that we need to do in terms of getting people around the table talking to each other between militaries and civilian groups so that they understand each other. I do think there's obviously a lot of data and a lot that we can take out from the experience of COVID-19 to inform guidelines and make them better for the future, and make them much more practical and relevant. And I would even hesitate to say that the Interagency Standing Committee draft guidelines, which have only ever remained draft, as well as the WHO guidance documents, arguably needs to be revisited in light of the COVID experience once we've got all this data and are able to analyse it all. So with that, thanks so much.
So thank you to all of our panelists and to all of you in the audience. And now is the exciting time where we have an opportunity for questions and discussion. I know we have a number of people in the room who have a lot of expertise and knowledge themselves on this topic. And so I think we have about 45 minutes or so. So please don't feel shy at all. And you can direct questions to individual panelists, or you can provide your comments or thoughts on what you heard and reflections. And we have
for the live stream.
We have a microphone which you need to speak into so that folks at home can hear you. So we'll open it up. Anybody want to get started first? Mike Marks, one of our shyest participants.
That was before I knew there was a microphone. Yeah, Mike Marks from World Food Program. And this is really for everybody on the panel, because I really appreciate all of the comments and the work that you've done. But this is some of the issues that we face on the humanitarian side is this, well, there's two really. One is the term civil military is way too broad, and it can mean anything from civilian government, but we tend to use it on the humanitarian side as the humanitarian military, which I'm curious to get your input about whether there is a role for the humanitarians in working with militaries, because these are essentially domestic activities. We made an assumption, I think, from the United Nations side that COVID was a global pandemic, and therefore there would be a global response. We had talked with a lot of militaries in advance, and there was this idea that a lot of the response would go cross-border. And I think with the exception of NATO and maybe one or two member states, that really didn't happen. Everybody turned inwards instead of looking outwards. And so from the humanitarian side, we didn't really have a big role. We tried to pull some logistics capability from different countries, which wasn't really there. And then we kind of fixated on the internal policing, the protection issues, which I think is probably a mistake in the relationships. So I'm just curious, from the research that you've done, the trends that you've seen, is there a role for the humanitarian side to engage with militaries, or is this more of a domestic issue that really the humanitarians can kind of stay out of? If that makes sense.
To any of you, so anyone want to get started?
Okay. Yeah, I'll jump in then. I think to some extent it depends on... I agree with you that it was a very nationalised response in many respects. And to be fair, that's what we've seen also. Even Sam has read the work that I did on the response to the Ebola outbreak. It was very much a national bilateral response as opposed to a multilateral with regards to the role that the militaries played. At least when it came to, I think probably for Australia and the Australian government, there was a very strong interest in being able to support regional neighbours, and they opted to do that on a bilateral basis as opposed to utilising necessarily some of the multilateral arrangements that were in existence. And in that context, I think one of the biggest contributions where we did see the military playing a larger role came to then the vaccine distribution. So there were very strict rules. Obviously, Australia closed its national borders, so you weren't going... And this became a problem, ultimately, even for being able to deploy people to assist our regional neighbours, because it was a challenge then of how to get them back into the country, and they would be having to go into 2-week quarantine. They'd come out for 24 hours and they'd be deployed again, and so there was one guy that I've met who was in quarantine something like 200 weeks out of 365. That became a problem. But in that regard, the Australian government opted to utilise the Australian Defence Force to help transport and distribute vaccines to neighbours, rather than necessarily using some of the multilateral arrangements that were in place. That's not to say that they were excluded, but they just had an existing relationship, and they opted to use that direct focus to get the vaccines there as quickly as possible. So there's a lot that we can learn from that as to whether or not that's the most appropriate and the best way forward, and arguably vaccine distribution and allocations are going to be a very big point of global discussions now. So I guess hopefully we'll see a better mechanism come out of it. But I think it's not to say that they were excluded intentionally per se. I think they opted to use a different approach, but whether or not that was the best one.
A great question. I think it's really important for it to be documented how they experienced that period and how they worked with each other. But I think for me what was more surprising was the lack of complementarity, if we want to use that buzzword, between the humanitarian and development sectors. So what we saw in the initial 6-month period were traditional responses within national context of humanitarian actors, but then there being no transition over to development workers when we saw, say, the impact of massive job losses. So we went from being able to provide the usual emergency food, etc., that we would expect humanitarians to do, but then very little coordination with development actors, and activating connections to livelihood programs were being implemented at least in Southeast Asia. And I think for me that was more surprising, that areas where you'd think, and we talk about a nexus approach to, in different contexts, but usually involving humanitarians and development actors, but it was really absent in this context. So the humanitarian and military engagement within Southeast Asia, a lot of them, because they were drawing on their national staff, a lot of international staff had gone back home, that they already had pre-existing relationships, and so that was something that I think should be documented, because they were working with each other, whether it was Muhammadiyah in Indonesia as being one particularly good example, I think, of how they had activated themselves to respond to the COVID situation and work with militaries. And they also had to rely on them to get around Indonesia and other places. So I think, yeah, we absolutely need to document those experiences.
But primarily domestic in those.
Yeah, domestic context, yeah.
I can jump in as well, just to sort of add my third sense. I don't have anything truly revolutionary to contribute to that, but I think the really frustrating answer is yes, but it really depends. And that's true of all of, I think, the sort of whole theme of CivMil is just that how big of a can of worms it is depending on the context in which one's working. But in terms of the Sierra Leone work specifically that I did, as we glossed over, a lot of that focus was at those district Ebola response centers, and that's very much not the point of delivery. So that's about CivMil at the operational level where decisions are being made, rather than it being the interface between affected populations and the people providing assistance there. That's not to say that those interactions didn't happen. It just wasn't the focus of the kind of day-to-day issues that I was looking at. So essentially not tactical, not delivery, very much office-based daily coordination. Essentially, the Dirks took over the job of what would normally be done by the health cluster, right? I mean, it was the coordination of humanitarian activity at the operational level. There's a big question mark around whether or not that was appropriate or what to do with it, but in a lot of ways, I think it did work, or at least worked in ways that maybe the health cluster typically wouldn't be able to. Vice versa, it had limitations that the health cluster wouldn't itself have faced as well, so it was a bit on both sides. But there were a number of humanitarian partners that were present and seemed pretty happy to engage day to day. And I take it, and this is a question for you, I take it that when you say humanitarian partners, you mean international humanitarian partners. So you mean UN agencies, you mean INGOs predominantly.
Yeah, just looking to the next event, is there a role that we should be looking at now from kind of the humanitarian civil community? Or is this more of a domestic, it's going to be military, domestic military most likely, working with Ministry of Health? So, and I'm not trying to sign up the CivMil world for more work. It's just trying to figure out what it is that we should be doing now.
I may come in with one example. While doing research for our project, we came across a case in the context of Indonesia. I believe it's an international agency. I forgot about the specific agency that they assist the Indonesia government to build the information sharing system within their different ministries involved. So basically, in my opinion, our research, we find that there are specific tasks that international humanitarian community or CivMil coordination community can assist national government in different tasks. Yeah.
Is this Chatham House?
No, this is live streamed.
Okay, all right.
But tomorrow will be Chatham House. So tomorrow.
Let me just throw out to be controversial here then. I think one of the challenges that we've got when it comes to that question around multilateral and international humanitarian organisations, historically you've had very little reluctance from those actors to engage closely with militaries, right? For a variety of very good, legitimate reasons, but you've had nonetheless a historical tendency to avoid any sort of formal engagement or interaction. What we've seen over the last 20-odd years has been governments increasingly calling upon militaries to play this type of HADR role broadly defined, but particularly when it comes to health emergencies as well, because we're seeing more of them. But you've still got these historical biases and tendencies and paths of people not wanting to engage. And so I think when a genuinely global crisis comes along like COVID-19, it's very hard to expect governments as well as militaries as well as other sort of humanitarian organisations to suddenly find themselves in a position of being able to know who to talk with and how to collaborate in that sort of environment. And that's why I think everyone kind of went back to default settings, right? They're working in a national crisis. Their first and foremost priority is to their governments. If another government asks for assistance, then they're like, yes, we'll tee you up and we'll help you out. Intentionally, whether or not intentionally excluding UN agencies or other multilateral organisations, it never even was considered, I don't think. So I don't know that it was a slight per se. I think there was just simply like, right, we can do this, we know it's a crisis, let's just get on and do it. Is there a better way to do it? Yeah, sure, I'm sure there is, but I think it's going to require probably another couple of decades of really dedicated hard work of engagement and a commitment from all sides to actually get past of some of those ideological boundaries that we're seeing in the permeate this area of activity.
Other questions and comments? Back there, yes.
First and foremost, on the Ebola and the COVID, I've been involved in both of those from the UK response. It's interesting to see how the two have been covered off and how the UK dealt with them in slightly different, massively different ways. And just going on to the Ebola outbreak, in your research, did you cover off the training element, or was it just looking at the command and control piece? We certainly spent a lot of time on my deployment working with RSLAF and various partners and NGOs to help develop facilities, processes that we were all learning to a certain degree and having to learn very, very quickly to ensure that our response was appropriate.
It's a really good question. I'm sure you could probably jump in on that as well from the work that you did. Basically, yes, but actually I'd strip it back even further than that. So British military was there alongside the Sierra Leonean Armed Forces, did stand up some really impressive training, also stood up training in the UK for humanitarian aid workers to get their PPE training and so forth before they kicked out. But in Sierra Leone, one of the things which I think is so interesting was the fact that actually the UK had been there training since 2001, and through the what is mostly referred to as the ISAT program. I think it's the International Security Assistance and Assistance Team, that's the one. And so that was, I mean, I'm sure you know this, but for the others in the room, essentially post-Civil War, actually towards the end of the Sierra Leone Civil War, the UK government, including its military, was very centrally involved in essentially disbanding, completely reforming and standing up the now Republic of Sierra Leone Armed Forces. I mean, it was a really, really unusually central role in institution building, like ground up at the end of the Civil War, which meant that the Sierra Leonean Armed Forces and the British military were almost plug and play, because they were trained by British officers, they were trained to sort of British military mission command, and so while that program had wound down a lot in the years since, when British military came back in under Gritrock, there was a huge amount of relationship building, but also the fact that literally the militaries were organised basically identically, so the sort of everything kind of matched and you could run with it. It also meant that because of the fact that at the command centres, at the district level in particular, you're mostly talking about no one from the Sierra Leonean army being above the rank of, maybe it got up to colonel, but what it often meant was that you had people who had only experienced the post-Civil War RSLAF. They had come out and through, at the officer class level, a largely British-supported officer training program. So putting aside all the training that you are referring to, which is really fundamental to the day-to-day in terms of standing up the Ebola treatment centres, standing up everything else, there was a much deeper existing sort of culture of training and culture of engagement. That meant that I think you could not argue otherwise, that the officer class Sierra Leonean officers were really spectacular to work with, and that would not be something that you would see in every country, because that's a pretty unique program that the UK government had stood up in Sierra Leone.
We certainly felt that there were times we were pushing on an open door.
Yeah.
And the engagement. One thing that we did find is that UK med process for training is very much high fidelity.
Mm-hmm.
So it's person, scenario, situation based. If you look prior to deployment to Afghanistan, we run a full hospital exercise, which gave us opportunity to encounter amputees, for example. So we were unsure how well the RSLAF teams would respond to that level of training, but to our absolute surprise, they responded amazingly, to the point we had some Oscar-winning performances. So it meant that the training was well taken and cascaded outwards.
Mm-hmm.
So for us, it was a really positive experience of how we've utilised UK-based training methods, medical training methods, for the first time really outside of that.
Yeah.
And it was quite successful. So I was just interested to see if you covered that off in and seeing those responses, as to whether you covered the training element off and that side of the house.
Yep, and then just a quick final tie-on to that, because I could talk about it for far too long, was just that, as you referenced, you often were pushing against an open door, that a lot of people, specifically the military respondents, spoke quite a lot about the military complementarity. Because of this level of access and because of that historical training program, if there was a concern, for example, by the British government or the British Civil Service, that a way in which a Sierra Leonean army decision was being made was thought to be inappropriate, there was an absolute sort of trust of a behind closed door conversation where people could kind of sort of go to the side and have a chat privately, and it would be respected, and it didn't have to go through all the sort of traditional sort of diplomacy of the thing. The big sort of can of worms related to this, though, is therefore how much is the Sierra Leonean experience actually generalizable? Because, again, that's a pretty unique program, that, and it was an accident of history that ISAT was there for 15 years prior to the Ebola epidemic kicking off.
Other questions? Zain?
Thank you very much for the insightful presentation. I'm Zain Tayyib, and I work with UN OCHA. And basically, we have been assessing our work with WHO and potential partnership on many initiatives, including medical evacuation, pre-hospital management, but also we're actually in the process of establishing technical working group on CivMil in health emergencies. And I think many of these recommendations resonate with what our work is intending to achieve. So basically, most of us, or at least the UN, our work is directed by existing guidelines, by global guidelines. And because there's very limited literature or guidance around working between militaries and health workers or medical military health responders, I think it's critical to do more work on that one. And I think basically we have good practices, good lessons learned from the pandemics, from even other health emergencies. So I think from what I saw, or actually from what I have learned, the relationship between the military and health responders and UN international responders, including also CivMil officers, seems to be an ad hoc relationship and not systematic. So it's really important that we base our work on something that is more concrete. And so I wanted to maybe get your thoughts. I'm just taking notes, but I really would like to see how do we promote this relationship in a very in a systematic manner, and as OCHA actually delivers training courses on civil military coordination, perhaps also we are thinking about incorporating the health component, the health response component, and the civil military coordination in health emergencies, so we can sensitize health workers, military actors on what we do and how liaison can be done, how this partnership can provide greater achievements. So really just recommendations on how you see this, and if there are any points that you would like to provide me to take into my work with WHO, that would be great. Thanks.
I guess just a quick response here, or maybe not so quick, but we're in RSIS, we've got a project on humanitarian futures, so using strategic foresight in the humanitarian sector. One of the things that we've found is that before we even get into the particular context of whether it's health emergency or perhaps a climate emergency, etc., that we need to take a step back and look at the scenario that we're looking at. So it's really about scenario development. And what are the conditions under which you want civil military engagement, and to what extent? So those bigger questions, like what role do we see in what kind of situation? We've heard, I think, in this panel discussion that a lot of it was in a national context, but we hadn't, as a humanitarian sector, really expected to be operating in such a domestic context rather than an international one. So I think a lot more investment in developing scenarios is very important. Before we get to even the stage of, say, investing in developing a component for courses on a specific area, until we figure out some of those potential scenarios that we're looking at.
Yeah, so many things to say. So how to promote it in a more systematic manner. I mean, a lot of this is, there's no sort of magic, I was going to say bullet, but that's probably not the best analogy. There's no clear, like, the solution to this is hard work. That's what I'm trying to say, right? And it's regular, consistent hard work. So establishing formal partnerships and regular dialogues, I think, is probably, unfortunately still, where we have to start. In the research that I've done now, which has been, I guess, over more than a decade, looking at the response in West Africa, but even prior to that, all of the interviews that I've done talking to civilians and humanitarians, you often hear very similar sorts of stories coming out. You know, military's personnel saying, yes, the humanitarian community, they view us as baby killers, and, you know, and I had a great example of one serving military officers, that, you know, the humanitarian types that I'm talking about, the ones with the dreadlocks. And I literally then went to the German run SITU, the Severe Infection Temporary Treatment Unit that was in Sierra Leone, and the first person that I met at the gate was a German humanitarian worker with dreadlocks. But, you know, what was fascinating about the conversations that I had there with just, now that initiative was a German government arrangement where they sent humanitarian workers from the German Red Cross and the German military. Apparently they were overwhelmed by the number of volunteers from the German military to go help in West Africa. Sorry, it was Liberia, not Sierra Leone. And one of the things, though, that in talking with both sets of individuals was that humanitarian workers were like, oh, these are really good people. You know, and they were genuinely surprised that the military medical doctors that they were working alongside were actually caring about the well-being of humans, you know. And the fact that that was a revelation, also was kind of alarming in some respects, right? But this is what the problem that I'm getting to, or that I referred to earlier. We still have these mental blocks when it comes to this. And I think being able to get people in a room to sit down on a regular basis to actually start engaging in dialogue so that they understand each other's terminology is number one, so that they can actually communicate with each other, is a really important first step. And yes, we've got these handbooks like the Sphere guidelines and all the rest of it, and people, they're out there. I really genuinely wonder the extent to which they're taken up, though. And, one of the findings from the survey that I was referring to earlier, we explicitly asked about the Oslo guidelines. Now, keep in mind, the majority of the military personnel that responded to the survey were senior officers, so they're command individuals. And one of the questions that they were asked was, are you aware of the Oslo guidelines? Do you believe that they apply in this context, referring to a health emergency? 58% of them had indicated they'd never heard of the Oslo guidelines. So, there's knowledge issues, there's training issues, there's dialogue. And one of the big challenges I think that the military themselves would admit is their own rotation of personnel. People are rotated in and out of different posts on a regular basis. And so the relationships that you build with one group of people, they then get posted to a new role. And so that whole process has to start over again. So this is where I think, with some of the lessons learned that we've had from previous crises, when we're not seeing them being picked up and embedded into new training programs and structures and so forth, it's often because people have been moved on as well. And the same thing happens in government too, in the civilian sector too. So it's not like that the military are to blame here in that context. But I just think there's a whole lot of work there that we still need to do. And so focusing on formal partnerships and that, and I know that Danny's in the room, so I'm just going to sort of flag. But I mean, this is one of the things that we're trying to work on in our region, in the Indo-Pacific as well, is trying now to help create some sort of formal structure or process to actually facilitate that dialogue on a regular basis.
The only other thing I'll very quickly tie on, which doesn't really unfortunately answer your question, but I do think that this question of kind of this mental block of actually getting people to cooperate well and having an idea that people are antagonistic between the civilian and the military side of this is very real. But some of the content of the research in Sierra Leone, which is one example, was that over time, I think a lot of actors on both sides of that coin realized that it was the same coin, that actually they were way more similar in terms of how they operated and the ways in which they were responding than they thought. And so there's a huge diversity of actors when you start talking about humanitarian actors. I mean, that includes a massive array of different ways of operating, but a military typically is quite hierarchical. So is MSF. So is a public health institution. It's often relatively top down compared to what we would characterize as a grassroots agency. And so I think, there's often instances that I think that you'll see when people are made to engage, even if they don't necessarily want to, where there is recognition that there's more overlap, not just in sort of the interest of the mission, for lack of a better way of putting it, in the case of Ebola, to try to end the Ebola outbreak, but actually also just in the ways that people work and the ways that they try to solve problems. And I think that those kinds of synergies are really hard to find unless you're practicing them. And so, and the problem is, it's, often that means only when you're actually responding to a problem. And so you only figure it out as you do it. But I think that having dialogue and having those kinds of partnerships is a way to start to overcome that in advance to the extent possible. But ultimately, yes, it's really hard work because, a lot of people have very little bandwidth to do that until there is an emergency at hand.
Just another thought to add to the discussion is that the transfer of knowledge is always a challenge for different communities. And I am thinking within the same system, like health system, and there are different groups of people responding to different types of emergencies. For example, in natural hazards, certain types of medical workers and public health workers are involved, while in public health emergencies, and another group, then they have different exposure to civil-military coordination. Use maybe Southeast Asia as an example. Those responding to natural hazards may have better experience in dealing with the military or understanding of civil relations. Then within the public health system, they can exchange their experience and understanding of civil-military relations. Yeah, thank you.
Just add something. Adam just made me think of something. And it comes back to work that was done around 2018 with OCHA and the ASEAN. And it's the interoperability brief, which they came up with, and the concept of dynamic simplicity. Okay, it's a bit naff, right? But the idea was there that whatever the different languages that were being used to activate a response, that they could understand which one meant what in a very simple way. But I think it hasn't been used. Mike might have been involved in that work right at the time, so he would know more. But I'm not sure if that's still being used now. So the other issue is whether or not we're keeping all the work that's been done active.
So I have a question for the panel. As many of you know, our outbreak working group has been developing these practical recommendations for civil-military coordination and public health emergencies. Essentially, as you mentioned, Adam, trying to fill in some of the gap in guidance that exists with the current Oslo guidelines. And, we've identified a number of ways in which public health emergencies are very different from other types of acute onset natural hazards. Number one being that most acute onset natural hazards occur over minutes to days, but a epidemic unfolds over months, and that means that you have, or years, and so it means that you have aspects of it that are in the preparedness, mitigation, response, and recovery phase all at once. Number two, unlike floodwater, where everyone can agree where the flood line is, with a virus, it's an unseen disaster, and so you can have greater risk for rumors and misinformation, and community engagement and risk communication becomes even more important than in a traditional acute onset disaster. And then finally, there's also the issues of force protection, whereas, militaries might be very willing to come in after an acute onset natural disaster where they don't see the same sort of risk to their own personnel. They are very risk adverse when it comes to a possibility where their own personnel might get sick or might experience negative effects. Based on these differences and based on your research that all of you have done, if you could add an extra chapter to Oslo's guidelines specific for public health emergencies, what are some of the additional guidance you think is needed in it in order to ensure that our civ-mil coordination in future public health emergencies is better than it's been in the past? And this is assuming, of course, that everyone reads it and promulgates it. That's obviously an important step. But you have to have the guidance first before you can even do that.
Maybe I jump in first.
Please.
Because as Al mentioned just now, in Southeast Asia or in the Asia-Pacific, countries have to respond to natural hazards while during the pandemic control. So we mentioned in our slides that the concurrence of different types of disasters at the same time is going to be likely and increasingly likely in the future. So in my opinion, maybe one part or section about like concurring disasters or concurrence of different types of disasters, and that within that context, how protocols should be specified can be useful. Yeah. Thanks.
So the assumption that there's only one disaster at a time is often not true, and so there needs to be guidance.
I'm not sure that I'm going to be able to help you with that, because my response would probably be to junk the Oslo guidelines and start again. And I say that genuinely. So part of my own perspective on the guidelines was really upturned by a discussion that I had while I was in Ghana. I was meeting with someone from the Kofi Annan Humanitarian Centre, Humanitarian Civil Military Centre. And they made the observation that, it's fine for you Western countries to talk about militaries being used as the last resort. For us, they're the only resort. And I think this whole concept of last resort has become an impediment, and I think we heard that earlier today in Jonathan's talk as well, that people, when they hear it, they don't even understand the distinctions that actually they don't apply in domestic contexts. And all we've got is a saying that's embedded into everyone's mind that works in this space, oh, the military is the last resort. Well, actually, I think we need to move away from that and acknowledge the fact that in some instances, we need to actually engage the military early. And it's one of the issues that I'm flagging, even with regards to the current negotiations around the pandemic treaty. In the event that our next pandemic is a result of an intentional biological event, we would have a variety of different actors involved than what we would currently being envisaged, right? So the military and security services would be much more heavily involved from the beginning and taking a much more stronger lead role in the event that the next pandemic is instigated as a biological event, intentional biological event. And so I think there is a cause for us they were great in 1994. I don't discount all the valuable work that went into them, and I am sorry if I'm offending anyone that was involved in the negotiating of the Oslo guidelines. They have done a fantastic job in establishing some principles, but I think we now need, however many decades on it is, to think about actually revisiting them all, and that may actually mean junking them entirely and then sort of starting again. Yeah. I knew that I'd get a response.
Well, Sam, did you want to say anything, or should we give it back?
Sure, I'll try and tie on to the comment. I mean, the Oslo guidelines aren't intended to apply to domestic context, but they do in reality because people assume that they do, even though I think they're relatively clear that they don't. And I think that, perhaps that maybe is my answer to that question, which is trying to provide a set of a framework of which people at the domestic level can think about and consider what needs to be thought about on a country-by-country basis, because I personally think that, especially when it comes to public health emergencies, it's incredibly dangerous to think about militaries as last resort, to draw on that principle, because when you have something like an outbreak, it's a problem that can escalate unless you intervene quickly. And so intervening as soon as possible to try to mitigate what could become a bigger problem is something that should absolutely be at the forefront of people's minds as you start to get signals that a health emergency is coming. I could talk about this for far too long, but I will leave it at just perhaps by saying, trying to reflect on the various comments, that the chapter I would add is on what is guidance that is relevant to guide international militaries deploying to another country, and what are specific considerations that are or are not relevant in that guidance when applied or thought about domestically, and to try to be really clear about which set of points and which points of guidance you are considering in relation to each of those two things.
Yeah. Mike, you had some?
Yes.
Right. Take the mic. Mike, take the mic.
Thanks. Sorry. Just to follow up on that, I don't disagree, Adam. The Oslo guidelines need to be updated. They reflect a context that never was and never will be, that everybody puts all their assets under the UN and we move forward. The challenge is losing the principles and concepts in the guidelines if we throw the baby out with the bathwater, and that's always the discussion. If I were to put a chapter in the Oslo guidelines, it would be just one page at the very front in giant font that says this does not apply to domestic. Mm-hmm. Because that is the whole nuance of what's going on. And this is the whole debate between first resort, last resort. It doesn't apply to how a sovereign nation uses their domestic military. And they have every right to use it the way they do. Last resort doesn't even preclude using military as first responders. It just says you should look at these factors before moving forward. And so you have these really nuances that I think that we just gloss over rather than kind of digging into what the reality is. This is what I was trying to get to earlier is there a role for the humanitarian civil military space. Because it could be that we just jump in there and make a mess of it. Because we've always kind of left the medical piece to the side and let medical talk and coordinate with medical, because they're much better at it than bringing in kind of the mainstream humanitarian, and using the humanitarian international NGOs, the MSFs, the IMCs, the rest of them, to do that coordination rather than kind of bringing in this side structure to put in place. I don't think we need more guidance on this necessarily, because I think that may make the response less agile, less effective in the end, because we're going through all of these systems. Sorry.
Yeah, I mean, I completely agree. I think much more education can be done around the fact that the Oslo guidelines don't apply to domestic militaries. But the next public health emergency, may not be just like the last one. We're always sort of planning the next one based on the last one. And so it may not be a COVID scenario where it's mostly domestic militaries being used. It may be more like an Ebola scenario in West Africa where you had foreign militaries, or it may be an Ebola scenario in DRC where militaries were involved in a conflict zone in responding to a public health emergency. And I think it's those situations where it gets more complicated, and where some nuance might be helpful. And last resort, I think, by itself is also too black and white, because it might be that you want to avoid the military for certain things, but for other things, you want to use them right up front. And so having a better sort of nuance around that, even though it's impossible to predict every scenario, might be helpful to future planners. But of course, then once you have the guidance, like as you've all said, ensuring that everyone actually knows it and that it's, available to the officer on the ground is a different scenario entirely. Yes, please.
Yes, this is a great session. My name is Bernard. I'm a PhD student at Georgetown. I'm also at the Center for Global Health and Security, a former peacekeeper with the Ghana Armed Forces. I was a captain deployed to Liberia, and then obviously during the COVID period where we responded, and also to DRC in 2018, 2019. I'm happy that Mike brought the issue of looking at the nuanced situation, both the domestic and also within the global health actors, like civil and military coordination at the domestic level, and then at the global health level. The comment I want to make is when it comes to at the domestic level, we should also be conscious of geopolitical settings. Like when we use research and Sierra Leone as a case study. So we have the Ministry of Health and Sanitation. They have the mandate to supervise all health issues. And an outbreak comes, military comes in, hey, step aside, we are the efficient guys, we are the disciplined guys, step aside, we are taking over. One, it undermines trust, it undermines institutional capacity. And I'm sure, obviously, for more than years, they've had training with external stakeholders. And so they are supposed to be the lead in, and obviously get support, but not like a militarized operation to, undermine their effort. I'm saying this because continuous use of the military in such geographical setting can also empower them, change their operational doctrine, and who knows, the next thing will not be pandemic, but coup. It's a setting where easily some guy can wake up, hey, the civilian guys are not efficient, and so let's step in, like Mali or Burkina Faso. And so those nuances must really be taken into consideration when it comes to geopolitics. And obviously, if we say that the military is the last resort, as in Ghana or those sub-regions, we say, then we will eventually perpetuate coups, because that notion that, civilians are not effective, they cannot handle emergencies or outbreaks or whatever, and so quickly let's move in and take the seat of power, which obviously perpetuate emergencies, it's continued, so it become like a cascading issue. And so I'm happy that we are trying to analyze those nuances to the domestic and then also at the international level. But then my question will be, so after the Sierra Leone lessons from the research, after the militarization of the operation, moving forward, was there any institutional learning whereby the civilian agencies, i.e. the Ministry of Health and Sanitation and other civil agencies were brought into the fold to continue and also to keep a place or a regulation to keep the military at a certain level, and when and how they can come in and coordinate with the civilian agencies?
It's a good question, and actually I wish I had a better answer to it, because I think a lot of things got confused because of COVID again, right? Another emergency starts, and so I think plans and sort of decisions around activating lessons learned, in some ways there was a great opportunity to activate them, but in another sense, another emergency came along and everyone's reinventing the wheel again. My knowledge of the post-Ebola sort of direction, there was an attempt to do that. So the National Ebola Response Center and the District Ebola Response Centers, which were civil military, were then in, I think, the 1st of January of 2016, handed over to essentially civilian coordination to do the sort of enhanced surveillance in the months, the final months of the outbreak, because you had to wait some time with no cases before you could declare it over. There was also a Public Health Emergency Operations Center that was stood up, so that had not existed before, the FEOC. And the FEOC, which was actually attached to one of the military bases in Freetown, was intended to be a center out of which civilian actors could activate quickly in response to a particular health emergency. The problem was, visiting it a couple of years later, that even after not a very long time, 2 years, because there was no emergency to respond to, it was just an office. And so people were kind of just sitting around. There wasn't that much to do. Every once in a while, maybe there would be a case of measles and they could become activated, but actually measles response, they were already pretty good at that at the district level in Sierra Leone, so there was no real relationship with the national government to do that. There was some continued efforts, and actually other people in this room might know more about it than I do, in relation to, for example, there was a sort of joint civil-military response team that was set up of something like 50 or 75 personnel. It had external funding from external partners. There's been a lot of lab work to try and help capacitate some of the laboratories in the country. But I think realistically, unfortunately, I think a lot of the lessons that could have been drawn to some extent fell away over time. And I think that that's pretty normal. I would love to hear insights of people working in other contexts and other emergencies, whether or not they saw the same. But realistically, I think a lot of lessons get lost very, very quickly. And so that's when we talk about these being ad hoc issues, like this is part of it, right? People are really bad at remembering what to do and how to do it, because so much of it is relationship built. I mean, you talk about the cycle of military coming through, it's the same in the humanitarian world. And so it's a problem on both sides of this. Anyway, I'm rambling at this point. But it would be good to talk about it later offline as well, just to talk about some of the other changes in Sierra Leone. Yeah, because it's an interesting question. It's a good question.
We probably have time for one last question from the audience. All right, last question.
Lots of work done and going on to the COVID response worldwide and the use of militaries in various aspects of rolling out care from the hands-on all the way through to the organisational side. Has there been much work that you've seen on public perception of that and how the public have responded to having the military around delivering hands-on care? I led a small team vaccinating patients in South Wales. That small team was largely made up of infantrymen who had never given any form of injection in their lives, so we had to train them up appropriately. But the response locally was absolutely fantastic. They loved the fact that I had 4 6'4" massive guys running around with needles giving vaccines. So it'd be interesting to hear what whether you'd heard anything from the worldwide
sort of response from the public?
The short answer is no. Again, this is focusing on data which has been publicly reported. So you do see some instances in media reports that, you know, by the military being engaged, that this has been a welcome development. There's often, though, there's a number of reports whereby people are concerned because it's also then been followed very quickly with reports of violence and human rights. So I think it is very varied, and I think that goes also to some of the challenges that we confront in this space, because I think every country, and this goes for the West African Ebola outbreak as well as COVID, every country has got its own different experience with the role of militaries and their experience of the militaries. So for my country, Australia, we don't even blink an eye if we see a member of the Australian Defence Force walking down the road in a uniform. But if you take that to some of the communities in Liberia, for instance, they would still remember the Civil War, and so that is both invoking of trauma but also a lot of fear involved, and so you get very different responses. And I think that's one of the challenges then when we're sort of trying to sort of think about sort of what are the lessons that we take away from this, because I think each response has to be contextualised as much as possible, and for some countries it's very appropriate, for other countries it's not. I even had a point where, because I was working quite closely with the Australian Department of Foreign Affairs and Trade in the first 12 months of the pandemic, also whereby there was talk about our desire to help with vaccination drives up in Papua New Guinea. And I, at one point, said, look, you know, I can potentially be deployed, but I said, I'm a former emergency nurse, but my registration is LAP, but I'm happy to... And they're like, no, we don't want a white man going in there giving vaccinations to the Indigenous population, right? That's not the look that they want. They want it done by local people and all the rest of it. And then you're like, yep, actually, very good point. So, yeah, I think it all is context-specific.
I will jump in just because it's such an awesome question. And when I referenced before in my presentation that I had done 200 interviews in Sierra Leone, but that I actually had to not consider 90 of them because I was one person and couldn't find the time. Those 90 were directly with communities, Ebola-affected communities, and saying, how did you actually understand it and receive the services of military performing functionally non-military roles? But however much it was a shame not to have the opportunity to analyse that data and to do something with it, thereafter worked with Brown to do a multi-year research project based out of the Watson Institute on including community perceptions of the role of military in health emergencies. And so that looked at Ebola in DRC, it looked at the refugee crisis in Rukban on the Jordan-Syrian border, and it looked at Tal volcano response and also COVID response in the Philippines. And it wasn't exclusively only about this issue, but a big part of that project was trying in each of those cases to speak with crisis-affected community members and essentially say, how do you understand the role of military performing, what was the term? Non-typical, you were saying before, there's like non-typical security functions.
Non-traditional security.
Non-traditional security. So performing non-traditional security.
Or MOOTs, military operations other than war.
Yeah. And you know, it's fascinating. So we have a paper that's on its way out at the moment. It's in review on exactly this question. Essentially, I could talk about it for too long, but the short version is it's hyper-context specific again. In Rukban, you know, in a lot of ways, we were looking mostly at speaking to the Jordanian army rather than looking at the Syrian army because we weren't able to access Syria. People, you know, I think a lot of people who were coming to the border and seeing the Jordanian army really had a sense of protection and security, that they were leaving Syria and coming to a place where they felt they had less risk as they engaged with military in that sense. Ebola and DRC, complete mixed bag. Some people of crisis-affected communities really appreciated and supported the role function of not only military but also non-state armed groups. Sorry, this is a huge research project. So also looking at non-state armed groups, also looking at gendarmerie and so on and so forth. And then again in the Philippines it was kind of a mixed bag, but more than happy to talk about the details of that and also share the paper that we have on it. It's a fantastic question. It's one people don't focus on enough. And when we talk about civil military, we already talked about the fact that the term is too broad, too vague, and not well understood. But I think that this part of the civil side of it, the civil engagement and the engagement with civil society, is massive, and it's one that we usually forget to include or consider when we're having this conversation. So it's a really good question.
I'll add that we just got a grant actually to do a study, unfortunately only based in the US, but we're going to be able to do a poll of a random sample of 1,000 Americans specifically to ask the question of how they thought of military being used during the COVID pandemic, from everything from providing vaccines to providing care in the hospital to driving school buses and all the various things that military did here. So it'll be interesting. I have some theories about how I think that they will respond, but it'll be interesting to see the data, and it would be very interesting to see similar representative surveys from other countries too.
Can I just add one final point on that? One of the recommendations that I would have there is to also consider the military families. Mm-hmm. So the survey that I mentioned earlier, one of the clear indications from that data is that the military personnel themselves that were deployed on these missions had a measure of concern about their own potential death and or severe illness. But inevitably, when they responded to the question, and everyone did, that answered this question, were you concerned? They also knew that their family members were also concerned, and their family members had a disproportionate or higher level of concern about the potential death of their serving family member than the member themselves. And this is often, when we're thinking about, if we want to do more training and we want to sort of get better at this, being able to communicate with the military families, because one of the elements here is that they accept a level of risk. Their loved one has gone into war fighting. They accept that there are a certain amount of risks associated with that career, but they don't anticipate or accept the risk that their loved one may die from being deployed to deal with a virus.
Mm-hmm. I'd echo that. My wife was more concerned with me going to Sierra Leone than she was for me going to Afghanistan.
Yes.
Yeah, it was always surprising to me. I came back from Liberia before the U.S. sent its forces and had some meetings with some folks at the State Department, and they asked me, is it safe to send our military to Liberia now? And I said, you're in Iraq, you're in Afghanistan. Anyway, with that, we'll call this panel to a close. I want to thank the panelists again for their research and presentations.